share practical tips, and help you build confidence for any clinical setting. Let's get started with how to properly prepare for the assessment. Preparation is key before any assessment. Start by reviewing the patient's chart for medical history and current concerns. This helps you focus your assessment. Gather all necessary equipment: stethoscope, pen light, blood pressure cuff, thermometer, pulse oximeter, gloves, and a watch. Introduce yourself, explain the assessment, and get the patient's consent. This builds trust and eases anxiety. Ensure privacy and comfort. Close doors, adjust lighting, and only expose areas being examined. A well-prepared environment sets the stage for a smooth, accurate assessment. Now, let's begin with the general survey. The general survey starts the moment you see your patient. Observe their level of consciousness, appearance, and signs of distress. Are they alert, comfortable, or in pain? Note hygiene, nutrition, and grooming. Sudden changes can signal underlying issues. Check for attached devices, IVs, oxygen, catheters, and note their status. These first observations provide a baseline and may reveal urgent issues. With this information, you're ready to move into more detailed assessments. Next, focus on non-verbal cues. Observe posture. Are they relaxed, rigid, or in a position suggesting pain or distress? Watch their movements and gait for coordination or signs of weakness. Assess mood and effect. Does their expression match their words and situation? Listen to speech for clarity and pace, and relevance. These subtle clues reveal much about physical and emotional health. You're now building a strong foundation before any hands-on exam. Now assess mental status and consciousness. Ask if they know their name, location, date, and reason for being there. This checks orientation to person, place, time, and situation. Document as Ando X4 if all are correct. If not fully alert, describe their state: lethargic, obtunded, stuporous, or comatose. Any change from baseline is a red flag and must be reported immediately. This assessment is crucial for detecting neurological changes. With orientation established, you're ready to proceed to the next system. After establishing the patient's mental status, the neurological assessment continues with an evaluation of the pupils and a brief screening of the cranial nerves. The pupillary assessment is a quick yet powerful window into brain function, particularly the brainstem. For this, you will need your pen light. You will be checking for PERRLA, an acronym that stands for Pupils Equal, Round, Reactive to Light, and Accommodation. First, simply observe the patient's pupils in normal room lighting. Are they the same size, equal, and are they perfectly circular round? You would note their size in millimeters. A normal size is typically between 3 to 5 millimeters. Any inequality in size, known as anisocoria, could be a normal variant for some people, but can also signify a serious neurological event. Next, you will assess their reaction to light. Dim the room light slightly if possible to make the response more obvious. You will bring your pen light in from the side of the patient's face and shine it directly into one eye for a moment. You should observe the pupil you are shining the light on constricting briskly. This is the direct light reflex. At the same time, you should also observe the other pupil constricting as well. This is known as the consensual light reflex. You must repeat this process on the other eye, always checking for both the direct and consensual responses. A sluggish or absent response to light is an abnormal finding and warrants urgent investigation, as it can indicate increased intracranial pressure or nerve damage. The final part of PERRLA is checking for accommodation. This tests the ability of the eyes to adjust their focus from a distant object to a near one. To do this, ask the patient to focus on a distant point on the wall behind you. Then, hold your finger or a pen about 15 centimeters from their nose and ask them to switch their focus to it. As they shift their gaze from the distant object to the near one, you should observe two things happening simultaneously. Their pupils should constrict and their eyes should converge, moving slightly inward. This coordinated response confirms that the accommodation reflex is intact, completing your PERRLA assessment. Finally, you will perform a brief screening of several key cranial nerves to assess motor and sensory function of the head and neck. While a full cranial nerve exam is extensive, a quick check is a standard part of the head-to-toe assessment. You can ask the patient to smile, frown, and raise their eyebrows to check cranial nerve 7, the facial nerve. Ask them to stick out their tongue and move it side to side to check cranial nerve 12, the hypoglossal nerve, to check cranial nerves 3, 4, and 6, oculomotor, trochlear, and abducens. Have them follow your finger with just their eyes as you trace the 6 cardinal fields of gaze. Finally, ask them to shrug their shoulders against the resistance of your hands to test cranial nerve 11, the accessory nerve. This quick screen provides valuable data on neurological integrity. Following our neurological checks, we now move into the HINT assessment, which stands for head, eyes, ears, nose, and throat. This part of the examination focuses on the structures of the head and neck. We begin with a general inspection of the head itself. Observe its size, shape, and overall contour. Is it normocephalic, meaning it appears symmetrical and appropriately proportioned to the rest of the body? Take note of any visible injuries, lumps, or depressions. With gloved hands, you should then gently palpate the scalp. Part the hair in several places to get a clear view of the skin underneath. You are feeling for any tenderness, masses, or lesions, and inspecting for any signs of infestations, such as lice or skin conditions like seborrheic dermatitis, which presents as flaking or scaling. Next, focus your attention on the face. Observe the patient's facial expression once more. Does it appear symmetrical at rest? Ask the patient to smile, frown, and puff out their cheeks. As we noted in the neurological section, this tests the facial nerve, cranial nerve 7. But it also allows you to assess for facial symmetry during movement. Any drooping on one side of the face, for instance, could be a sign of a stroke or Bell's palsy, and is a critical finding that requires immediate reporting. You should also inspect the skin on the face, noting its color, texture, and the presence of any rashes, lesions, or edema. Periorbital edema, which is swelling around the eyes, can be a sign of fluid retention related to kidney or heart conditions. We then move on to a more detailed inspection of the eyes. We have already assessed pupillary response, but now we examine the external structures. Look at the sclerae, the white parts of the eyes. They should be white and clear. A yellowing of the sclerae, known as jaundice, can indicate liver disease. Redness or scleral injection may suggest conjunctivitis or irritation. Inspect the conjunctivae by gently pulling down the lower eyelids. They should be pink and moist, not pale, which could signify anemia. Also, check the eyelids for any ptosis, which is drooping, lesions, or styes. Ask the patient if they have experienced any recent changes in their vision, such as blurriness, double vision, or any pain. A Snellen chart can be used for a formal visual acuity test if concerns are raised. Finally, in this section, we complete our initial head and facial assessment by checking the sinuses. Gently palpate or press over the frontal sinuses, located just above the eyebrows, and the maxillary sinuses, found on the cheekbones on either side of the nose. Ask the patient if they feel any tenderness as you apply pressure. Pain upon palpation in these areas can be a significant indicator of sinusitis, which is an inflammation or infection of the sinuses. This information, combined with the patient's report of symptoms like nasal congestion or facial pressure, helps to form a more complete clinical picture. This systematic inspection of the head and face provides a wealth of data before we even look inside the ears, nose, or mouth. Continuing our HINT assessment, we now turn our attention to the ears, nose, and throat. Begin by inspecting the external structures of the ears. Look at the auricles or pinnae for shape, size, and their position on the head. Note any deformities, skin lesions, or signs of inflammation. Gently palpate the auricle and the tragus, the small piece of cartilage in front of the ear canal. Tenderness upon palpation can be a sign of otitis externa, commonly known as swimmer's ear. Using your pen light, look into the external ear canal. You are checking for any discharge, excessive earwax, redness, or foreign bodies. Ask the patient about any hearing loss, tinnitus, or vertigo, which is a sensation of spinning or dizziness. Next, we inspect the nose. Examine its external appearance for any asymmetry, deviation, or lesions. To check for nasal patency, you can ask the patient to occlude one nostril at a time and breathe in through the other. This simple test helps to determine if there are any obstructions. Using your pen light, tilt the patient's head back slightly and look inside the nares. Inspect the nasal mucosa. It should be pink and moist. A pale or bluish swollen mucosa might suggest allergies, whereas a red and swollen mucosa is more indicative of an infection. Take note of any discharge. Is it clear, bloody, or purulent? Also, observe the nasal septum for any deviation, which could potentially obstruct airflow and cause breathing difficulties. The final part of the HINT assessment is the examination of the mouth and pharynx, also known as the oral cavity. Ask the patient to remove any dentures if they wear them. Begin by inspecting the lips for color, moisture, and any lesions like cracks or cold sores. Using your pen light and a tongue depressor, inspect the inside of the mouth thoroughly. Look at the buccal mucosa, the gums, and the teeth. The mucosa should be pink, smooth, and moist. Note any inflammation, ulcers, or white patches, which could indicate conditions like thrush. Assess the condition of the teeth and gums, looking for signs of decay or gingivitis. A dry oral mucosa can be a key indicator of dehydration. Finally, inspect the tongue, the floor of the mouth, and the hard and soft palates. Ask the patient to stick out their tongue and observe it for symmetry and any coatings or lesions. Then ask them to say, "Ah." This action should cause the soft palate and the uvula to rise symmetrically in the midline. This movement tests the function of cranial nerves 9 and 10, the glossopharyngeal and vagus nerves. While they are doing this, you can visualize the posterior pharynx or throat, looking for any redness, swelling, or exudate on the tonsils. A comprehensive oral examination is crucial, as it can reveal signs of systemic diseases, nutritional deficiencies, and dehydration, completing our detailed hint assessment. Now we proceed to the respiratory assessment, a crucial evaluation of the patient's breathing and lung function. This assessment begins, as always, with careful observation. Before you even place your stethoscope on the patient's chest, you must inspect their breathing. Watch the rise and fall of their chest for a full 30 seconds to determine the respiratory rate, then multiply that number by 2 to get the breaths per minute. A normal rate for an adult is between 12 and 20 breaths per minute. Simultaneously, you should assess the rhythm and depth of their respirations. Is the breathing pattern regular and even, or is it irregular? Are the breaths shallow, normal, or excessively deep? This initial observation provides a vital snapshot of their respiratory status. Next, you must observe the effort of breathing. Is the patient breathing comfortably and quietly, or do they appear to be working hard to breathe? Look for the use of accessory muscles, which is a classic sign of respiratory distress. This is when the patient uses muscles in their neck, such as the sternocleidomastoid or the intercostal muscles between the ribs, to help them breathe. You might see the neck muscles tighten with each inhalation or the skin between the ribs retracting. Also observe for any nasal flaring, particularly in children, which is another sign that the patient is struggling to get enough air. These visual cues are red flags that indicate the patient's breathing is compromised and requires immediate attention. With these initial observations complete, you can now prepare for auscultation, which is the act of listening to the internal sounds of the body. You will use your stethoscope to listen to breath sounds over the chest wall. It is essential to listen directly on the skin, not over the patient's gown or clothing, as this can muffle the sounds and lead to an inaccurate assessment. Ask the patient to take slow, deep breaths in and out through their mouth each time they feel your stethoscope touch their skin. Breathing through the mouth reduces the sound of air moving through the nose and allows for clearer auscultation of the lung fields. This is a key instruction for obtaining the best results. To ensure a comprehensive assessment, you must listen to the lungs in a systematic pattern, comparing one side to the other. You will auscultate in at least 6 locations on the anterior chest and 8 locations on the posterior chest. A common technique is the ladder pattern, where you move your stethoscope from one side to the corresponding spot on the other side, moving downwards. This bilateral comparison is critical because it allows you to detect any differences in breath sounds between the left and right lungs. For example, diminished sounds on one side could indicate a pneumothorax or a pleural effusion. This methodical approach ensures no lung fields are missed and provides a complete picture of air movement. As you auscultate the lungs, you are listening for the character and quality of the breath sounds. Normal breath sounds are known as vesicular sounds, which are soft, low-pitched sounds heard over the majority of the lung fields during inspiration, with a shorter, softer expiration. However, you must also be alert for any adventitious or abnormal breath sounds. These are extra sounds that are not normally present. The most common adventitious sounds you will encounter are crackles and wheezes. Crackles, sometimes called rails, are short, popping sounds that are most often heard on inspiration. They can be fine, like the sound of hair being rolled between your fingers, or coarse, like the sound of Velcro being pulled apart. Crackles are typically caused by fluid in the small airways or alveoli, and they are a hallmark sign of conditions like pneumonia or heart failure. Wheezes, on the other hand, are high-pitched, continuous musical sounds, almost like a whistle, that are usually heard more on expiration. They are caused by the narrowing of airways, which forces air to move through a smaller passage. Wheezing is the classic sound associated with asthma, but it can also be present in patients with bronchitis or anaphylaxis. Another adventitious sound to listen for is stridor, a loud, high-pitched crowing sound heard on inspiration, which indicates an upper airway obstruction and is a medical emergency requiring immediate intervention. Beyond auscultation, a complete respiratory assessment includes palpation. You can gently palpate the chest wall to check for any tenderness, masses, or crepitus, which is a crackling sensation under the skin caused by air leaking into the subcutaneous tissue. You can also assess for tactile fremitus, which is the vibration you can feel on the chest wall when the patient speaks. Ask the patient to say 99 each time you move your hands. Increased fremitus can suggest consolidation, as seen in pneumonia, while decreased fremitus might indicate an obstruction or fluid. While not always performed in a routine screening, it is a valuable technique when a respiratory abnormality is suspected from your initial findings. Finally, always integrate your findings with the patient's subjective report and other objective data. Ask them, are you experiencing any shortness of breath or a cough? If they have a cough, ask if it is productive of any sputum, and if so, what color and consistency it is. Check their oxygen saturation level using a pulse oximeter. A reading below 95% on room air is generally considered abnormal. Look at their fingernails for any signs of cyanosis, or a bluish tinge or clubbing, which is a deformity of the nails associated with chronic hypoxia. By combining your inspection, auscultation, palpation, and patient interview, you build a robust and comprehensive picture of their respiratory health. Following our detailed respiratory examination, we now move seamlessly to the cardiovascular system, which is intimately linked to respiratory function. This assessment is fundamental to evaluating how effectively the heart is pumping blood and perfusing the body's tissues. We begin by assessing the heart's rate and rhythm directly by locating the apical pulse. The apical pulse is found at the point of maximal impulse, or PMI, which is located at the fifth intercostal space, just medial to the left, mid-clavicular line. To find this spot, you can trace down from the sternal notch to the angle of Lewis, slide your fingers over to the second intercostal space, and then count down to the fifth space. This is the most accurate location for assessing the cardiac pulse. Once you have located the apical pulse, you will use the diaphragm of your stethoscope to listen for a full 60 seconds. This is non-negotiable, as it allows you to accurately determine not only the rate, but also the rhythm of the heartbeat. Is the rhythm regular, with a consistent lub-dub sound, or is it irregular? An irregular rhythm, such as that found in atrial fibrillation, might feel regular if counted for a shorter period, which is why a full minute is the gold standard for accuracy. While listening, you are also noting the heart sounds S1 and S2. S1, or lub, is the sound of the mitral and tricuspid valves closing, and S2, or dub, is the sound of the aortic and pulmonic valves closing. These should be clear and distinct. After assessing the central pulse, we move on to evaluating the peripheral pulses. This is crucial for assessing the adequacy of blood flow to the extremities. You will palpate the radial pulses located on the thumb side of the wrist, simultaneously. This allows you to compare them for equality. Are they both present? Are they of equal strength? You should grade the pulse strength on a scale typically from 0, meaning absent to 4+, which is bounding. A normal pulse is graded as 2+. Palpating both at the same time provides immediate comparative data. A weaker pulse on one side could indicate a vascular issue like a clot or stenosis affecting that limb, specifically. Next, you will continue this assessment by moving down to the lower extremities. Palpate the dorsalis pedis pulse, which is found on the top of the foot, and the posterior tibial pulse located on the inner aspect of the ankle, behind the ankle bone. Just as you did with the radial pulses, you must assess these bilaterally, checking for presence, strength, and equality. A weak or absent pedal pulse can be a significant finding, suggesting poor arterial blood flow to the feet, a condition known as peripheral arterial disease. This is particularly important to assess in patients with diabetes or known cardiovascular conditions, as it can be an early sign of serious circulatory compromise. Beyond assessing pulses, a thorough cardiovascular assessment involves looking for other key indicators of cardiac function and tissue perfusion. One of the quickest and most informative tests is checking the capillary refill time. This is done by gently but firmly pressing on the patient's nail bed for a few seconds until it blanches or turns white. You then release the pressure and count how long it takes for the normal pink color to return. A normal capillary refill time is less than 2 to 3 seconds. A prolonged refill time, often called sluggish, indicates that blood flow to the peripheral tissues is compromised, which can be a sign of dehydration, shock, or peripheral vascular disease. Next, you will inspect the patient's extremities for any signs of edema, which is the swelling caused by excess fluid trapped in the body's tissues. Look at the ankles, feet, and shins, as this is where edema due to gravity is most commonly seen in ambulatory patients. For bedbound patients, you must remember to check dependent areas like the sacrum. Gently press your thumb into the skin over a bony prominence for about 5 seconds. If an indentation remains after you remove your thumb, this is known as pitting edema. You should grade the severity of the pitting, typically on a scale from 1+, meaning mild, to 4+, which is very deep pitting, providing objective data on the patient's fluid status. While inspecting the extremities, you should also be observing the skin's color and temperature. The skin should be warm, dry, and of a color that is appropriate for the patient's ethnicity. Feel the skin on both arms and both legs, comparing one side with the other. Are they symmetrically warm? One limb that is cool to the touch compared to the other can be another sign of an arterial occlusion. Look for cyanosis, a bluish discoloration of the skin and nail beds, which indicates a lack of oxygenated blood. Also, look for pallor or paleness, which can be a sign of anemia or poor perfusion. These visual and tactile clues are vital pieces of the cardiovascular puzzle. Finally, a comprehensive assessment also involves listening for abnormal heart sounds. While listening at the apical pulse, you should be alert for any murmurs, which are whooshing or swishing sounds caused by turbulent blood flow through the heart valves. You should also listen for any extra heart sounds, like S3 or S4 gallops. While a full cardiac auscultation over all 4 valve areas, aortic, pulmonic, tricuspid, and mitral, is a more advanced skill, being able to identify a basic murmur at the apex is a fundamental part of the screening assessment. By combining all these findings, pulses, capillary refill, edema, skin assessment, and heart sounds, you create a detailed picture of the patient's entire cardiovascular system. Following the cardiovascular system, we now focus our assessment on the abdomen to evaluate the gastrointestinal system. This assessment follows a specific and crucial sequence: inspection, auscultation, percussion, and then palpation. It is critically important to auscultate before you palpate or percuss the abdomen. This is because pressing on the abdomen can alter the frequency and character of bowel sounds, potentially leading to an inaccurate finding. To begin, position the patient comfortably in a supine position with their knees slightly bent. This helps to relax the abdominal muscles, making the examination easier and more comfortable for the patient. Ensure the patient's abdomen is fully exposed from the xiphoid process down to the pubic symphysis, while keeping the rest of their body appropriately draped to maintain dignity. The first step is inspection. Stand at the patient's right side and look across the abdomen, then view it from the foot of the bed. You are observing the overall contour. Is the abdomen flat, rounded, scaphoid, or protuberant? Note its symmetry. Are there any visible lumps, masses, or hernias? Observe the skin for any scars from previous surgeries, striae, rashes, or lesions. You should also look for any visible pulsations, particularly around the umbilicus, which could indicate an aortic aneurysm, a critical finding. The umbilicus itself should be inspected for its position. It should be midline. Signs of inflammation or any bulging, which might suggest a hernia. Next is auscultation. Using the diaphragm of your stethoscope, you will listen for bowel sounds in all 4 quadrants of the abdomen: the right upper, right lower, and left lower quadrants. Place the stethoscope gently on the skin and listen in each quadrant for up to a minute, or until you hear sounds. Normal bowel sounds, often described as borborygmi, are high-pitched gurgling or clicking noises that occur irregularly, anywhere from 5 to 30 times per minute. You should note if the sounds are normoactive, hyperactive, or hypoactive. Hyperactive sounds are loud, high-pitched, and frequent, which can suggest gastroenteritis. Hypoactive sounds are very soft and infrequent, which may indicate constipation or a developing ileus. The complete absence of bowel sounds after listening for 5 full minutes is an emergency. After auscultation, you can proceed with palpation. Begin with light palpation, using the pads of your fingers to gently press down about 1 centimeter in a rotating motion across all 4 quadrants. This is to assess for any superficial tenderness, muscle guarding, or large masses. Watch the patient's face for any nonverbal signs of discomfort, such as wincing. Ask them if they are experiencing any pain as you palpate. If they reported pain in a specific area, always palpate that area last to avoid causing unnecessary discomfort and muscle guarding that could interfere with the rest of your examination. Deep palpation is a more advanced skill used to assess deeper organs and masses, and is typically performed by advanced practitioners. A comprehensive gastrointestinal and genitourinary assessment goes beyond just the physical exam of the abdomen and really involves a focused patient interview. It's essential to ask about the patient's usual bowel habits, since what is normal can vary a lot from person to person. One key question you'll want to ask is, when was your last bowel movement? This simple question can provide a wealth of information. You should also ask about the consistency and color of the stool, and you might use a Bristol stool chart if needed to help the patient describe it more accurately. Be sure to inquire if they've experienced any recent changes in their bowel habits, like new-onset constipation, diarrhea, or any blood in the stool. Blood could be bright red or dark and tarry, which can indicate bleeding at different locations within the GI tract. Similarly, you need to ask about the patient's appetite and dietary intake. Questions like, how has your appetite been recently? Or, have you experienced any unplanned weight loss or gain? Are important. A loss of appetite, also known as anorexia, can be a symptom of many underlying conditions. You should also ask about any nausea, vomiting, or indigestion, which is called dyspepsia. If the patient has been vomiting, it's important to ask about the frequency and the appearance of the vomitus. Does it contain undigested food, or does it look coffee ground, which is a classic sign of a slow upper GI bleed? These details are crucial for piecing together the clinical picture and identifying potential GI pathologies that might need further investigation. The genitourinary assessment often relies heavily on the patient's subjective report, especially during a routine screening. You need to ask about their urinary patterns. Some key questions include, are you experiencing any pain or burning when you urinate, which could point to a urinary tract infection? Ask about the frequency of urination. Are they going more often than usual? Do they feel a sense of urgency? You should also ask about any difficulty starting the stream of urine, known as hesitancy, or any incontinence, which is the involuntary loss of urine. For male patients, especially older men, these symptoms could be related to prostate enlargement. Finally, you must assess the patient's urine itself. Ask about the color of their urine. Is it a normal pale yellow or straw color, or is it dark amber, which could suggest dehydration? Is it cloudy or foul-smelling, which are classic signs of infection? Have they noticed any blood in their urine, a condition called hematuria? If the patient has a urinary catheter in place, you can directly observe the urine in the drainage bag, noting its color, clarity, and volume. For all hospitalized patients, monitoring their fluid intake and urinary output is a fundamental nursing responsibility that gives you a direct measure of kidney function and overall fluid balance, really completing your comprehensive GI and GU assessment. Following the abdominal assessment, we now evaluate the musculoskeletal system, which assesses the body's framework, movement, and strength. This part of the examination often integrates smoothly with other sections, as you have already been observing the patient's gait, posture, and ability to move in bed. We begin with a more focused inspection of the extremities, looking for overall size, shape, and symmetry. Are the limbs of equal length and circumference? Observe the joints, the shoulders, elbows, wrists, hips, knees, and ankles, for any swelling, redness, or deformities. Any signs of inflammation or structural abnormality could suggest conditions such as arthritis, an old injury, or a congenital issue. Note any visible muscle wasting, also called atrophy, or involuntary movements like tremors. Next, we assess the patient's range of motion, or ROM. This can be done passively, where you move the patient's limbs through their range, or actively, where the patient moves them independently in response to your instructions. Active ROM is preferred as it also provides information about their strength and coordination. Ask the patient to perform simple movements for each major joint. For example, for the shoulders, you can ask them to raise their arms up in front of them and overhead, then out to the sides. For the knees and hips, ask them to bend and straighten their legs. Note if the movement is smooth and full, or if it is limited by stiffness or pain. Listen for any crepitus, which is a grating or crackling sound within the joint during movement. After assessing range of motion, we evaluate muscle strength, which is a key indicator of both musculoskeletal and neurological health. A simple and effective way to do this is by testing strength against resistance. For the upper extremities, ask the patient to grip 2 of your fingers with each hand to test their hand grip strength, making sure you compare both sides for equality. To test arm strength, have the patient push and pull against your hands with their arms, a movement often called push-pulls. For the lower extremities, ask them to push their feet down against your hands as if pressing a car pedal. This is plantar flexion. And then pull their feet up towards their head against your resistance, which is dorsiflexion. Finally, if the patient is able to walk, a gait and balance assessment is essential. Observe them as they walk a short distance, if it is safe to do so. Note the smoothness, rhythm, and symmetry of their stride. Is their gait steady, or do they sway or require support? Are they able to turn without losing their balance? This functional assessment provides critical information about their mobility, independence, and, most importantly, their risk for falls. A comprehensive musculoskeletal examination combines this observation of function with the hands-on assessment of joints and muscle strength, giving you a complete picture of their physical capabilities and limitations, which is vital for planning safe and effective care. The moment you inspected the patient's face and scalp to when you examined their extremities, you have been gathering data about their skin. Now, we consolidate these findings and perform a more deliberate check. You are inspecting the skin for its color, looking for any pallor, which means paleness, cyanosis, which is a bluish tint, jaundice or yellowing, or erythema, which is redness. Note any variations in pigmentation, as well as the presence of any rashes, bruises, scars, or unusual moles. It is important to look everywhere, including skin folds between the toes and on the back and buttocks. A key component of the integumentary assessment is checking the skin's temperature and moisture. Using the back of your hands, palpate the skin on the arms and legs, comparing sides. The skin should be warm and dry. Skin that is cool to the touch may indicate poor perfusion, while excessively warm skin can be a sign of fever or inflammation. Is the skin diaphoretic, meaning excessively sweaty or abnormally dry? Dry, flaky skin can be a sign of dehydration or a thyroid condition. These simple tactile assessments provide significant clues about the patient's circulatory and hydration status, reinforcing findings from your cardiovascular and genitourinary assessments. Another critical assessment is checking for skin turgor, which is a measure of the skin's elasticity and is a reliable indicator of hydration status. To check turgor, gently pinch a fold of skin over the patient's clavicle or on the back of their hand and then release it. In a well-hydrated person, the skin should snap back to its original position almost immediately. If the skin remains raised or tented for a few seconds, this is known as poor turgor and is a classic sign of dehydration. This finding is particularly important in elderly patients or those who have been experiencing vomiting or diarrhea. Finally, a crucial responsibility for nurses is to assess the patient's skin integrity, with a specific focus on identifying areas at risk for pressure injuries, also known as bed sores. Pay close attention to bony prominences where pressure injuries are most likely to develop, such as the sacrum, heels, elbows, and hips. Look for any areas of non-blanchable erythema, which is redness that does not turn white when you press on it, as this is the first stage of a pressure injury. Document the location and size of any wounds, rashes, or breaks in the skin with precise detail. For at-risk patients, using a formal assessment tool like the Braden scale helps to quantify this risk and guide preventative interventions. Often referred to as the fifth vital sign, pain is an entirely subjective experience, meaning that what the patient says it is what it is. It is our responsibility to assess it thoroughly and advocate for its effective management. The assessment begins with a simple, direct question. You should ask the patient, "Are you experiencing any pain or discomfort right now?" If the patient denies having any pain, you can document that they report their pain as 0 out of 10. However, if they affirm that they are in pain, your assessment must then delve much deeper to gain a full understanding of their experience. If pain is present, the next step is to quantify its intensity. The most common tool used for this is the numeric rating scale. You would ask the patient, on a scale of 0 to 10, where 0 is no pain at all, and 10 is the worst pain you can possibly imagine, how would you rate your pain right now? This rating provides a crucial baseline that allows you to track the effectiveness of any pain relief interventions you provide later on. For patients who are unable to use a numeric scale, such as young children or individuals with cognitive impairments, you must use an appropriate alternative, like the FACES pain scale, which uses illustrations of faces to help them communicate their level of discomfort. Quantifying the pain is only the beginning. A truly comprehensive pain assessment explores its various characteristics using a mnemonic like PQRST or OLDCARTs. You need to ask about the provocation or palliation. What makes the pain better or worse? You must investigate the quality. Can you describe what the pain feels like? Is it sharp, dull, aching, burning, or stabbing? Then determine the region or radiation. Where exactly is the pain located? Does it travel or radiate anywhere else? You also need to assess the severity, which you have already done with the pain scale, and the timing. When did the pain start? Is it constant or does it come and go? Finally, it is essential to understand the impact of the pain on the patient's life and their goals for its management. Ask them, how is this pain affecting your ability to sleep, eat, or move around? This helps to contextualize the pain score and prioritize interventions. You should also ask, what would be an acceptable level of pain for you? This question involves the patient in their own care plan, setting a realistic goal for pain management. For example, a patient with chronic pain might find a level of 3 out of 10 acceptable, allowing them to function, whereas a patient with acute postoperative pain will have a different expectation. This collaborative approach ensures patient-centered and effective care. The next critical step is documentation. The head-to-toe assessment is of little value if the findings are not documented accurately, thoroughly, and in a timely manner. Your documentation creates a legal record of the patient's condition at that point in time and is the primary tool for communicating your findings to the rest of the healthcare team. Use your healthcare facility's specific charting system, whether electronic or paper, and be sure to record your findings using objective, professional language. Document both normal and abnormal findings clearly and concisely, avoiding vague terms in favor of specific descriptions. Remember the key principle of documentation. If it was not charted, it was not done. Your notes should paint a clear picture of the patient. For example, instead of writing "breath sounds bad," you would document coarse crackles auscultated in bilateral lower lobes posteriorly. Instead of "patient seems sad," you would write "patient quiet and withdrawn, reports feeling overwhelmed by diagnosis, affect is flat." This level of detail is essential for continuity of care and allows subsequent healthcare providers to accurately track any changes in the patient's condition over time. Always double-check your documentation for accuracy before finalizing it. Finally, the conclusion of your assessment is not just about charting. It is about critical thinking and action. As you review your findings, synthesize the information. What are the most significant abnormal findings? What are the patient's priority problems right now? Any critical or unexpected findings, such as new onset chest pain, a sudden change in level of consciousness, or signs of respiratory distress, must be reported to the charge nurse and the patient's doctor immediately. The head-to-toe assessment is the foundation of the nursing process. It is the data that drives your diagnoses, your care plan, and your life-saving interventions. Mastering it is a continuous journey, but it is the most powerful skill you possess as a nurse.